Hello and welcome to our panel discussion on the use of order set protocols to improve quality and safety in healthcare. I'm Dr. Nikki Curtis. I'm a GP by background, also have a background in health informatics. I work at the moment as a clinical specialist for BMJ. Now, I often go out and talk to NHS organisations about how they can achieve their objectives, improving patient safety or quality or even cost efficiency. And we have a wealth of evidence-based guidance out there that will enable us to do this, but the trick is to try and get that high-quality knowledge to the right person at the right time and in a format and through a channel that's actually applicable to that context. Now, order sets or action sets from BMJ are a way that we can actually achieve this. But the key has to be implementation, and that can be a real challenge. So we've got a panel here today to discuss some of the issues around this. And if I can just bring them in now. Tracy, can I get you to tell us a little bit about your role?
Sure. So my name's Tracy Time. I'm an anaesthetist in Newcastle, New South Wales, Australia. And I'm also a half-time clinical lead for the New South Wales Agency for Clinical Innovation. We're also doing a lot of work around this sort of area, and so the implementation interests me a lot as well.
Mm-hmm.
I'm Fiona Watson. I'm Director of Transformation and Quality at Melbourne Health in Melbourne, Australia. My role is to manage the quality and safety team and the improvement team in our organisation, also focusing on improving patient experience. So introduction of these order set protocols is something that our team and myself would be heavily involved with in promoting.
Hi, my name's Hamid Desai. I'm a GP in the UK, and I'm also Associate Medical Director for Bupa in their corporate centre. So I look after quality and governance across the Bupa group in all of the markets.
Okay. Hello, my name's Wajiha Sagir. I'm one of the Foundation Year 2 doctors working at Queen Elizabeth Hospital, King's Lynn at the moment. We're heavily involved in action sets via the use of care bundles at the hospital, which I've been heavily involved in.
Great. So just to kick off the discussion, Hamal, what do you see as the real value of order sets?
Well, I'm very interested in order sets. I think they're one of those elements and one of those initiatives and tools that we can use to not only improve quality, but also drive efficiency as well as cost benefits around the system. So it's one of those initiatives that I think can initiate clinical interest, but also from a managerial point of view, management interest as well, because it drives reduction in clinical practice or drives reduction in the variances of clinical practice whilst improving the outcomes for patients. So I think it's a value-based initiative that addresses the whole spectrum for me, and that's why I think it's an important element from a value perspective.
And do you think there is a distinction to be drawn between EHR implemented order sets and order sets like the innovative way that they're using them on paper in King's Lynn? Is the value only with EHR integration?
No, I think it's wider than that, actually. I think integrating with EHR, I think, can bring additional benefits, but I think the idea and the concept around care bundling and using order sets within care pathways can be done regardless of an electronic or any other format. So I think it's the principles behind driving a care pathway and using diagnostics in a particular way, rather than the means by which you do it. I think if you integrate it with EHR, then I think it has additional benefits and allows you to drive probably better outcomes through a more efficient process, but I don't think it's the only way.
Mm.
Just add there too, I think that the benefit's not just in the product of the, whatever you want to call the care set, but also in the development of them, and that's one of the things that we've been working and concentrating on in New South Wales, is getting consensus. So our care sets are actually primary to acute care, so they cross further along the patient pathway. And the process of getting primary care and acute care, doctors, nurses, allied health staff together has probably been the most valuable part of it. Understanding the barriers and enablers from both sides, and then redesigning pathways that currently don't work based on evidence, evidence-informed, not always completely evidence-based, depending on the local requirements.
And you mentioned barriers there. What are your feelings? What are your thoughts on some of the barriers that may be in existence?
I think primarily there's issues around the technology that's available. Quite a lot of the health services in Australia don't have electronic health record, so there isn't really the platform to have broader communication with order set terminology, and which is another issue that in Australia it's not a common language around calling these order sets. The language is more around care pathways and bundles is the more usable conversation, and also the development of pathways and broadening out to secondary and primary care collaboration. So I think also barriers could be reaching consensus amongst clinicians around what's the most agreeable and most evidence-based approach to look after a certain condition, a certain patient. And that can be difficult in some instances, and particularly when you bring in the more multidisciplinary teams as well. And then I think just time. I think we know that these kind of things take a long time to develop, and you need space and resources to do that.
They can save time once they develop.
They can, that's right. But it's just investing in that up front and getting the right people involved and getting agreement.
I think part of the challenge around getting clinical consensus is part of the issue actually as well, because people deal with different or the same problem in different ways, and therefore driving efficiency through a pathway I think is critical with order sets and actually a commonly agreed care pathway. One of the ways in which, when we've initiated similar projects before to try and gain consensus, has been to give that freedom and that autonomy to work outside an order set where it's necessary to do so, but capture why people are moving outside an order set, because that's important to improve the order sets anyway. And I think giving that comfort that people use the order sets as set, but there is some autonomy there, and people will be able to move away from that should they require clinically to do so, gives that level of autonomy that I think, and that comfort that some clinicians need, where they feel that their practice is being restricted. And that can help to overcome some of those barriers.
Which is one of the other benefits of having the sets stored electronically. You can automate feedback, you can automate measurement of variance, whereas paper requires physical audits, and that can be very time consuming.
And I think in this sort of era of more partnership with our patients is this sort of concern that the care won't be able to be individualised, which is so important.
We'll move back to that a little bit later. But Wajiha, you were involved in the development of some of the paper-based care bundles in your hospital. Can you tell us about your experiences with that and your experience of using them?
So we've been using the care bundles in Queen Elizabeth Hospital in King's Lynn for 8 or 9 months now, and I was there when it initially started, and have produced some of the care bundles as well. So the care bundles that we use are in the form of a sticker that we place in the patient's notes, and the other side of the sticker we place in another box for auditing. And that sticker that we place in the patient's notes, it has crucial criteria such as diagnostic criteria and management criteria as well, and it guides you so that you know where to go. For example, in the case of an ACS protocol so that you know when to refer to cardiology, when an echo is required, because these sorts of things are not always easy to know when you're working on the shop floor. When producing these care bundles, we've used national guidelines as well as local guidelines, which are very important, and we've used a combination of them to produce them. And I think it's an excellent tool using the care bundles, because having that up-to-date guidelines at the bedside and making important clinical decisions at the bedside with the patient, it's very useful. I think it's also been beneficial to the junior doctors and also to medical students who are coming for the first time to work in, for example, the medical assessment unit. And it's a very, very busy environment, and you need to know what is important, the criteria that is very important at that stage. And the care bundles have been useful to help guide the junior doctors, is what we've found, and keep up to date with the guidelines. Initially, when the care bundles first came out, there was some concern from the junior doctors because they were worried that the care bundles were too robotic in their use, sort of like a tick box exercise, and devaluing the reason that just coming out of medical school, you think of the value of a doctor. But actually, having used them for 8 or 9 months now, and we update them constantly, and we have forums in our hospital with the junior doctors asking their opinion of the care bundles, and we've actually found now that people are finding them a useful tool for clinical decision making at the bedside, especially in the busy medical assessment unit, when you might forget important criteria.
Great, and you're starting to get some fantastic results with them, which is brilliant.
We've actually started auditing the care bundles because we've used them for 8 or 9 months now, and we found auditing different conditions, for example, community-acquired pneumonia. Before the care bundles were put into use, patients who might have needed blood cultures, for example, only 30% of patients were getting those blood cultures, but after the input of the action set care bundles, now 70% of patients who need blood cultures on admission are actually getting the blood cultures now, which is quite a substantial improvement.
Excellent. And you've very extensively localised sort of a generic order set to use in your organisation. I'll come to you, Tracy. What are your feelings about localisation? Do we always need to do it, or sometimes is it appropriate just to roll out a generic set?
I think the decision to roll out a generic particular set is a local decision. Mm-hmm. So localisation, I think, is really, really important. It goes back to the thing I was talking about, the collaboration and the process of developing relationships between groups of people that might not have sat down and talked to one another before. So that's very, very important. The second thing is that the capacity and capability of the services to which the bundle points is really, really variable. Something that might work in the middle of metropolitan London certainly won't work in the outback of Australia, because the services and the access to diagnostics, the skill set of the staff, the distances that people have to travel are all quite different. So very, very important to localise. The other thing I was going to say, I've forgotten what it was now, but the localisation also doesn't just support the collaboration, but supports the buy-in. So it's bringing in clinicians at the start who can then own the care set. And I think that the richness of the discussion that comes out when you're localising something is amazing. Often people are unaware of how poorly the current process works. And when you have to map it and articulate it, there's often, in our situation, we find people go, this just isn't good enough. We need to redesign this. So let's scrap what we're currently doing. Don't describe that. Let's make something that's much, much better for patients. So, and you can build in measures, you know, at the start.
We have a similar process in Bupa. We develop clinical efficiency guidelines, which are essentially care bundles and with action sets within them. And because we're a global organisation, even though these efficiency guidelines are produced corporately, they need to be localised in the context. So how care is delivered in Spain is very similar, but how people access different services within that local setup will be different. So how they can apply those efficiency guidelines and sets, it becomes very much a local decision. It's different to how it will be done in Australia or UK, in Chile and in other places. So it's very important that local context is very important. Plus, as you mentioned, getting the clinicians around the table, and not just the clinicians, the organisations around the table, becomes an important part of the implementation process. And if you want the implementation to work well, then that localisation has to take place. And really it's around the care pathway as a whole that needs to be developed. And as you said, when you sit down and discuss how care is currently being delivered and how you envisage that care to be delivered in the future, it starts to unravel lots of different elements of structure and process and systems, and what areas clinicians need to develop in and be trained for as well.
I think it adds to transparency of services that are supplied, and I think that's really important for the public and for patients to understand as well. So the processes we're using locally, I know, as I said, they cover the pathway from primary care into hospitals and hopefully back. But I know GPs are literally turning their desktop to patients and saying, this is what we can provide, this is what you should expect, and this is why I'm not going to refer you at this point, you know, to a specialist, because we're going to need to try all these other things first. And this is where all those things are available locally. So I think transparency is an important benefit of it as well.
I'd just like to go back to a point that was made earlier around the use of sets. So in general practice, when I was training to be a GP a few years ago, there were order sets that were there that you would have in conjunction with your local hospital for certain general practice common conditions seen in general practice, for example, tiredness all the time. There would be a set of things that you would do, you would manage in a particular way, and then you would refer or action depending upon what the causes were. Similarly in hospitals, one of the things that I felt worked best when I was a junior doctor was a management of MIs, which was essentially a very protocol-driven approach. The management in A&E of fractured neck of femur, again, highly protocolized in our units, and the variance is that if I was a patient coming into the hospital, the care would be much the same regardless of who was on shift for those conditions, because they were very highly protocolized and had a set of actions that led off the back of that and ultimately drove better care. But there was that clinical autonomy that you would have. So I think there are examples in the past that we can use and drive better care. But I think now, particularly with the introduction of electronic health records and other elements, I think we can increase the breadth of those and how we improve them in a more rapid way because of the information that we have and the ability to audit the success and the outcomes.
I think one of our care bundles was the ACS Care Bundle, and we've definitely found that implementing that care bundle, more junior doctors are understanding the GRACE score and how to use it, and we've noticed a smoother flow in decision making with the use of that care bundle, and everyone likes them.
Because you empower the junior doctors, you empower junior doctors to make decisions, whereas before it depended upon who the senior doctors working with you were to be able to make some of those decisions, and therefore because of the variances in how guidance existed. So.
That's fabulous. Sorry, Fiona.
Yeah, I think they also help with efficiency as well and cost effectiveness in hospitals, and particularly in things like length of stay management and discharge planning, so that you know, all of these sort of things are discussed with the patient. And you know, I think we've implemented hip and knee pathways, and they have hugely reduced length of stay in our organisation. So, you know, I think that's another dimension that these add, I guess, to healthcare.
Did they take a lot of work to get consensus on those?
Yes.
No, I was going to add that I think that this sort of thing is useful not just for junior doctors but for people at the other end of their career as well. The complexity of healthcare is so huge, and as you become more senior, you're taking on other roles around, you know, quality and safety and other leadership roles, and you have to switch your brain from this very big picture down to, you know, an anaesthesia, you know, what dose of which drug, and I think that they're a really big, you know, major support for quality and safety at the other end of your career as well. So,
I think the reason, going back to my original first point around the value of this, I think even from a patient and a relative perspective, it becomes extremely important, because if I was to go to King's Lynn and I was told that I have diagnosed with pneumonia, then there's an expectation that is set around the tests that I may get, or the length of time I may be in hospital, or the potential outcome that I may have because of the way in which the process has been laid out, and that information can be given early to me and my relatives, so that I can then plan. I can plan for my own discharge, or my family can plan for my discharge. And yes, things may not quite go to plan, but at least there is a plan at the outset, because I've been diagnosed with a particular condition, and I can rely then on the doctors and nurses to then support me, and the other professionals to support me during that time. So having that information early, I think, it would be quite beneficial. So.
We've heard quite a lot about actually how this sort of practice can help improve communication with patients. How important, Fiona, do you think it is maybe to start about thinking about involving patients in, you know, designing the performance indicators that we're building these around, about designing these protocols?
Yeah, there's a lot more emphasis on the patient experience and making sure that that's acknowledged in their care and in the development of these kind of tools. And in Victoria, there's definitely strategies around consumer partnering, and also nationally with new national standards that include partnering with consumers. So we're evolving from more of information giving and consulting once things are sort of halfway developed, to partnering and even to the extent of what Maureen Bisignano was talking about this morning around flipping care and trying to get more input about what's important to patients. And there's opportunity, I think, there with these types of sets to actually look at innovative ways to introduce them, rather than perhaps the sort of more traditional methods, and what are the true benefits to improving the patient experience.
On top of the patient experience, we've been using care bundles in our new ambulatory emergency care unit, and we're increasingly using the care bundles. And we also, in the AEC unit, we record patient experience as well, and so far there's been 100% patient experience, and that's one of the things I've come to present today about. And I don't think we would be able to get that 100% patient experience without the use of the action sets and the clear pathways that we have in our ambulatory care unit. So
I guess conversely, we don't have a huge amount of the order sets, but we do seek a lot of patient experience feedback, particularly post-discharge. And, you know, that's told us that we have got gaps in our discharge planning. We have got gaps in how we explain to use medication, what their medication requirements are on discharge and things like that. So we can build that into components of these pathways as well. Another thing that we need to acknowledge is those patients who don't speak English, and how do we communicate, and what's the best way culturally to engage, and how do we use some of perhaps external organisations to advise on the development also, and it's not just hospital based, as that's culturally diverse patients are. They have huge disparity in health outcomes, and how do we actually support that in the use of these?
We've introduced, we have what we've called our Brains Trust groups, and we have our Aboriginal health leader and his group, our migrant health group, and other sort of non-government agencies look at each of our pathways as we develop them. So they're in at the beginning to hopefully give us some insights if we're completely missing, and sometimes we will create another pathway for migrants, or if necessary, and it often is necessary. Yeah.
Yes, because some of the language, particularly if there's cancer related, it's quite difficult to find the right terminology.
And the other issue, I guess, in Australia, which I'm sure exists in other places too, is the inequitable access. So that sometimes it is necessary to create a different pathway, an easier pathway for groups who have traditionally had very poor access to a particular service, and therefore have a much greater burden of disease. So.
And finally, I just wondered if you could give us some thoughts, Amal, on the importance of clinical leadership in this whole picture.
One of the things that I missed out earlier was clinical leaders don't have to be the most senior clinicians within the context of the environment. I think clinical leaders can be at all levels within organisations and amongst all disciplines. It's those people who are able to inspire and, as I said, work with clinicians to implement the change. So I don't think it's at any particular level that we need to associate clinical leaders. I think it's critical. Clinical leadership is critical to the development of sets, to the development of pathways. One of the key roles for clinical leaders, apart from being visible throughout something like this, is to try and lead on gaining that clinical consensus. It becomes a very important aspect of whether any change will work or not, and getting a clinical body together to drive that change is one of the key remits of a clinical leader in this context. So I think it's very important, but it's also in supporting clinicians in the receiving end of some of the guidance and the actioning of some of these order sets. There were challenges throughout the implementation, and I think leaders have a duty to not only capture that but to support clinicians when it comes to implementation of the change, because any change makes people anxious, and where that anxiety exists, it's the job of clinical leaders to try and allay some of those concerns and fears, but also smooth the pathway, because they may be in a position to understand the impact of the changes than those that may not have that background. So I think it's a vital role that they play in not only taking the clinical body, in gaining consensus from the clinical body, but also to develop the arguments for change and then to support during the change as well. I think it's important.
So Tracy, I think you had a question for Wajiha.
Yes, I did, Wajiha. As a junior doctor, I'm really interested to know how your hospital let you know that these sets were available, and you obviously love them. So what's kept you using them?
Back when the care bundles were introduced about 8 or 9 months ago, we had groups from the BMJ come round and explain about action sets, and they explained that we were going to be using care bundles. And initially there was some anxiety about using them, and then the junior doctors have found that as we use them more and more, we are able to cover all aspects of clinical decision making at the bedside using national and local guidelines. And I guess it's just the satisfaction of knowing that we've covered everything that we need to cover at the bedside. It's quite comforting, and that's the reason I think that the care bundles are an excellent resource.
Thank you, and thank you to all our panellists. It's been a fantastic and very informative discussion, so thank you.